So here is the complex anatomy of the anal canal to just review. One of the difficulties here is that pathologists can't always define the canal as easily as a surgeon. So in the body, the surgeon can say, okay, I can feel this where the end of the anal sphincter is. But we have a harder time once we receive a specimen because we may not be able to feel or sense or detect that sphincter there. And so it's a little bit more complicated for us to define location. The anatomy is that we have these sinuses and we have these anal columns, which are covered by squamous mucosa and alternate with glandular mucosa here. There are, in each of the pits of these columns, little anal glands that have a columnar mucosa and a submucosal gland. And then the squamous mucosa here is non-keratinizing, but once you reach the anal verge, it becomes keratinizing. This is a slightly different origin than this, and the kinds of tumors will be different down here than they are up here. In terms of staging and function, the levator ani muscles and the anal sphincter are critical to function, and so tumors that can be resected without disturbing this musculature are much to be preferred from those that involve these muscles to any great degree. Okay, so I think that's where we'll go on to the next slide here. So we'll start with the external area here on the skin outside and talk about one of the things that we can see. And so a tumor that may occur here is an adnexal skin tumor. And these will form a lump or a bump, a mass that may be palpable to the patient and certainly should be recognizable to the surgeon. This is an example of a hidradenoma papilliferum, fairly common skin tumor of the perineum and perianal area that has a characteristic columnar type cell and an interstitial second type of cell, and a sort of sieve-like or papillary architecture. It makes them recognizable and fairly easy to differentiate. One of the other complexities when we start talking about the squamous neoplasms in the colon, in the anus, is that there are a variety of different naming systems out there. So most people grew up with kind of a conventional name of dysplasia, carcinoma in situ, condyloma, and there were some eponyms like Bowen's disease or Bowenoid papulosis that had particular clinical and pathological correlates. Then adapting the terminology from the cervix, as that was changing and we realized the problems with reproducibility, people said, well, let's just say anal intraepithelial neoplasia and call it 1, 2, 3, because we can't really tell these apart. And then the next group took that a step further and said, well, we really can't tell these two apart reproducibly, so let's just have two groups, have anal squamous intraepithelial lesion low grade and anal squamous intraepithelial lesion high grade. And then if we have the architecture or whatever, we can call it a condyloma and so forth. And then for the perineal or perianal skin intraepithelial lesion, these are high grade. We can't really tell these apart, even though the clinical presentations may be different. This in a young woman, this in an older patient. Well, this was still very confusing to some of our clinical colleagues. these variety of nomenclatures. And so recently, the College of American Pathologists and some of the perianal surgeons and gynecologists and so forth have said, let's get the naming down to one system. So they called it the lower anogenital squamous tumors. So that's the LAST acronym. It's a nice acronym if you think this is the last terminology change we're going to make. But it's fairly straightforward. The critical thing is to see that condyloma is moved in with the low-grade lesions. And we have a bow to, in a younger woman, you might say that this H-cell on the perineum is boenoid papulosis clinically. So this says histology here gets the same grade and term as histology somewhere else in the anogenital tract. The cervix, the vagina, the perineum, the anus, all gets this similar type of terminology. And that helps to standardize treatment. It also helps us to think in terms of cause and effect, because clearly many of these diseases are directly related to HPV type of viruses, and the same kinds of risk factors will be associated with that. So here's the very low end of the spectrum. We see the type of viral changes that can be seen with HPV virus. We see the architectural changes of a papilloma or a condyloma, and this would be a low-grade squamous anal, whatever location type of lesion, whether it's in the vulva or whether it's in the anus or whether it's on the penis or wherever. It would have the same grading and terminology. You know, it's still okay if you would like to use the mild, moderate, moderate and severe, or mild, moderate and severe. You tell me which one is moderate, which one is severe. This is the challenge, is that, you know, sometimes one person's moderate is another person's severe, and so these are difficult. But this is to be expected in the lesions in this area. And this is particularly true for the non-keratinized squamous surfaces of that anal canal. So these types of appearances would be like non-keratinized mucosa in the vagina or cervix. Now, differentiation is difficult sometimes between a hyperplasia and neoplasia. And this is one of the areas on the high-grade side of things where P16 staining can be very, very useful. So you look at these two and you say, those both look like high-grade lesion to me. Do they look like that to you? Yeah, very, very similar. But as you can see here, the reactivity with P16 is very different. So this might be a patient who has squamous atrophy or a reactive appearance, metaplasia, whereas this is a patient with obvious dysplasia. HPV is incorporated, and the P16 molecule is amplified, and it's diffuse positive staining. Now here you get a little bit of the transition, or it may be equivocal. You would not call an area that was staining like this positive, but this is positive. Here's another example, and this is an area where P16 staining is not useful. So if you're trying to differentiate a low-grade lesion from a reactive lesion, P16 isn't very helpful. Sometimes it will be positive, sometimes it will be partly positive, but sometimes it may be negative. I think these both turn out to be low-grade lesions, but you can see that the staining is inconsistent. So if your question is normal, low-grade, don't do P16. Use your morphologic criteria. Maybe Ki67 could help you a little bit, not always. but you're going to have to make that distinction. But if your distinction is high grade versus repair, that's when P16 can be very useful for your differentiation. So here's a nice chart of the histologic features that we use. We use the nuclear to cytoplasmic ratio. We use the presence of koilocytes. These are not usually present in reactive lesions. We can look at mitotic counts or activity, and especially Ki67 staining. That will be basal layers only in reactive lesions, whereas you may get some upper level staining with the low-grade lesions. Maturation, polarity, proliferation, that's the same as mitotic activity, and then the staining. So these are the tools that you have histologically to make the differentiation. And the differentiation is important because this will be managed differently than this in most patients. This will require attention, follow-up, surgical excision. This may just resolve on its own or just require colposcopic follow-up at a later point, maybe even cryotherapy or something. So then we come to the issue of early invasion, and this is much like any other squamous mucosa. We use the same tricks to look for invasion. When we see this sort of keratinization at an interface, we call that paradoxical deep keratinization. So usually the keratinization happens on the top, but if we see it happening on the bottom, then we become suspicious for invasion. When we see irregular buds like these, that also suggests invasion. When cells begin to acquire nucleoli, especially along this margin, that usually means that the invasion is incipient. And then the stroma with inflammation and desmoplasia. You know these very well from your training. Now, what do we do in terms of classifying and differentiating squamous cancers in the anal area? Grading differentiation does not have much prognostic value in the anus area. And so don't waste a lot of time